deep into the core, deeper stuff of diencephalon, thalamus, basal ganglia, internal capsule. Then we've kind of gone back and put the little ball of that mini brain of cerebellum into the picture. And now really what we're looking at is the spinal cord and the brainstem, in the opposite brainstem first, which are really just conduits of all this information we've been talking about. So these should connect some of the dots with some of those pathways or give them a little more functional meaning, if you will, when you look at these two areas. But the real key discussion, too, again, the real goal is not, we're not aiming to be neuroscientists. We aren't aiming to go into the lab and count axons under a microscope. Everybody's obviously looking at this from a clinical standpoint, but if you know your way functionally through these regions, I think you should be able to hold your own regardless of what neuro setting you're in or what pathology is kind of crossing your plate when you get there. So that's the intent, again, as we continue through brainstem and spinal cord. And the thing you don't think about these quite so much is the blood supply and stroke. Stroke, absolutely. You're thinking, oh, yeah, left side, right side, and blah, blah, blah. Maybe a little discussion as far as some of the other internal capsules and those lenticular striate or lacunar type strokes or small vessel strokes. But the brainstem is an area that, we've kind of joked about along the way. It's the area you don't want to screw up. This is really your core, foundation for keeping you alert and oriented and functioning. This stuff is only part of your function. Spinal cord, only part of your function, but the brainstem obviously is the core of it. So we're going to take a quick tour of duty through this. I'm going to briefly go over the anatomy, but I'm not going to be, again, plunking up a picture of the brainstem and saying, name this structure, name that structure, and so on and so forth. So when you look at the brainstem, connecting diencephalon, spinal cord, pretty straightforward. Everybody's, known it as pons, or midbrain pons, medulla, pretty straightforward. But the top of the thing, by definition, starts way up top here, these crisscrossing and the posterior commissures. Not as big as corpus callosum or any of that kind of stuff. And it ends down below, if you look at this, pyramidal decussation or crossing. The pyramids, these are the big motor tracks heading down from this motor cortex we keep talking about, going through the internal capsule, going down into the brainstem, basically running down the front of the brainstem, and a majority of them crisscross at the bottom of the brainstem and then go off their merry way to whatever muscle group they're going to plug into. And this thing is known as the pyramidal decussation, if you will, but we'll talk about those. But again, that's this area here where you see the crisscross. So that's where that's coming from. The divisions, as we said, midbrain, pons, medulla. Everybody's known that since 9th grade anatomy class. But the vertical piece, maybe not quite as much media attention. When you look at the brainstem, sometimes it's divided up into this terminology known as tectum, tegmentum, and basis. And for lack of a better word, it's really just posterior, middle, and anterior columns of this brainstem. The brainstem is a conduit. Things are going, all the way through it, whether it's going up or down, and things are emerging and starting in and out of it. So different, you'll find different structures in, the anterior, middle, and posterior. But that's where the terminology comes from. Sometimes you'll hear, tectum or tectile, that's what it's referring to. And then last but not least, the blood supply, as we said, really clinically, this is where we're going at. At the very end of this thing, I think I put out 2 or 3 quote-unquote common brainstem, infarcts, but there's, obviously others out there. But the thing I would point out before I even get into the nuts and bolts, the vertebral artery, basilar artery we've chatted about, but these little tiny blood vessels, these paramedian vessels that sneak out. So far, we talked before about small vessel stroke, and I only brought it up because we're talking about internal capsule, thalamus, and basal ganglia, and that's where those guys are supplied. But when it comes to these lacunar strokes, these small vessel strokes, they do involve the pons and this midbrain as well. So clinically, we'll see a lot of discussion about small vessel strokes involving or lacunar infarcts in the brainstem. So I guess I want to kind of put forth the concept of don't just put those small vessel strokes in a little category of internal capsule only is the name of the game. All right, so function-wise, blah, 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 you can read right through each one of these. As I said, it's a conduit. All the cranial nerve nuclei start there and emerge out of. There's a lot of interconnections between the cerebellum and everywhere else, as we had talked about. So really, that's all this is discussing. The only other thing I haven't chatted about this hypothalamus and autonomic nervous system. Sympathetics and parasympathetics too as well also travel through or emerge from the brainstem and have a huge role. So autonomic nervous system is has genuine concern that you've got a healthy brainstem. Hypothalamus is, I'm not sure if we've mentioned it, but it's kind of the junction box between endocrine and CNS. It's clustered nuclei below that thalamus that is projections going in all directions. But one of the directions are to these core centers in the brainstem. So that's where function is coming from. So looking again, backing up anatomy-wise, you look at this thing, you've seen those pictures, here's a brainstem, here's the front of it. When you look up top, looking at this is midbrain, this is pons, this is medulla down here. And you start looking at all these lumps and bumps, if you will. These two little bumps here, these are the mammillary bodies junctioning with part of the limbic system. Again, we're not getting too detailed into limbic through this module. But this is the infundibulum, part of that pituitary stalk, all that stuff we had chatted about. And then the optic pathways, so the crisscrossing of the optic tract and nerve, et cetera. So that's cranial nerve 2 making its way back. Actually, I should pause here. If you follow it, here's the chiasm. It's coming back. And as it lands back here, this big old lump back here is the thalamus. Again, just trying to get you oriented. And this is that lateral geniculate body. The lateral geniculate in the thalamus is where all your visual goes through and pops back to area 17. So anyways, that's the top part of things. So looking at the midbrain itself, this is it. This big white matter in the front, in the basis, anterior, are just all those big motor columns coming down, corticobulbar, corticospinal, that we'll go over. But that's where the name peduncle, cerebral peduncle, comes from, if you will. And then cranial nerves 3 and 4, the nuclei sit there, emerge out of there. I know I said we really aren't going over cranial nerves, and we're not. You may or may not have started your individual projects, but we will be kind of just skimming the surface discussion cranial nerve-wise in this brainstem lecture too, but it's not really all inclusive of them. So anyways, this is cranial nerve 3 sneaking out here, 4 wraps around the back, then you move down. And these guys, are just simply named kind of in a descending order, 5, 6, 7, and 8. I'm certainly not going to quiz you on them. 9, 10, 11, and 12. So it just kind of gives you a kind of an ordering or a visual of each of them as we discuss them. So, and some of the other landmarks, I'm not going to take the time really to discuss too much, other than, again, to point out the crossing or decussation of those motor tracts that are making their way down to the spinal cord. If you flip the thing around, we've seen this view with the superior, middle, and inferior peduncles making the connections to that cerebellum. So there's a dentate nuclei right there. But all the deep nuclei would be sitting here. There's all your cortex and all that stuff, blah, 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 that we just talked about. But if you look up top, this you see these 4 little bumps. These are the superior and inferior colliculi, but they're quote-unquote the tectum. They're kind of the roof of that back of the midbrain, if you will. The superior are all about connections visually, inferior all about connections auditory or vestibular from the ear, if you will. And we'll get to them in a moment, but these tectospinal tracts, tracts that originate in the tectum, that's why I'm connecting the dots with the semantics that we'll do with the spinal cord, are basically involved in those neck muscles coordinating, visual, auditory, startle, reflex, all that kind of stuff, if you will. So that's what these 4 little lumps and bumps are. They're the back of the midbrain, the roof of the midbrain, quote unquote, the tectum of the midbrain. So those are the ones I'd point out. Everything else, really not going to discuss too much. There's cranial nerve 4 sneaking its way around to the front. Move your way down to the pons. Only things I'd point out is really aren't seeing any cranial nerves like you do from the front side. And the 4th ventricle is the big opening there. That again, when we do CSF next module 6, we'll talk about flow pathways, et cetera. And that's about the extent of highlighting the different spots. And same thing, not really too much really to talk about as far as the medulla, so we'll kind of push that one along and move it right along. So again, when you visually look at this, it should make sense, but the biggest thing, here's the 4th ventricle, here's the superior and inferior colliculi, the tectum of that midbrain, as far as just giving you a nice little visual back there. And these are the peduncles that have been hacked off or sliced off in the dissection. All right, looking at it from the side, this is the more traditional view that, through the years people have looked at. The midbrain, the things to look at is the roof of this thing. That's the superior, inferior colliculi, so getting you oriented that way. You have the CSF pathway, so the 3rd and 4th ventricle are connected with this cerebral aqueduct. Is involved in one of these brainstem syndromes that may occur. Cerebral peduncle is really just referring to the basis at the front of that midbrain. But the other piece of it is this thing, the MLF, medial longitudinal fasciculus. There's a conduit in the brainstem that's involved in coordinating all this stuff we keep talking about, the eyeballs and the reflexes and the conjugate gaze and all that stuff. So it has to involve connecting cranial nerve 6, which is down lower, cranial nerve 3 and 4 up in the midbrain, motor cortex coming down to talk to these guys. So there's a conduit of information that's got information going up to the motor output of those and also other information going through it. And that's known as this MLF, and it's just this big bundle of white matter that's tracking that information up and down. So that's the MLF, and we'll talk about it a little further when we get into the functional roles. And then pons and medulla, nothing but a continuation. So again, 4th ventricle, MLF. I'm not going to put again, a picture up on the test and have you identify it, but if you visually connect the dots to some of the things we're chatting about, I think it'll make it easier to chew and swallow the functional piece of it all. So when you look at a dissection or a plastinated limb, you should be able to start to pull out some of this stuff. There's that cerebral aqueduct, there's the 4th ventricle, 3rd ventricle up here, but this is the midbrain up here. There's the colliculi, superior, inferior. All the way in front is the pathway of those motor tracks. So something blowing out the front is going to have a huge impact on, motor execution and things along those lines. These two back here, as we said, a lot of that visual or auditory or inner ear reflexes, core, innate type of reflexes. So the next question is about the middle stuff. This is where all those cranial nerve nuclei sit, and it's also where all the ascending tracks, or a lot of the ascending tracks, make their way through the brainstem. So when you look at it, through those vertical segments, we start to tweeze out the difference between the front, the little bit in the back, and then the meat and potatoes of the middle part of it. All right. So blood supply. When we look at this, we have talked about the vertebral arteries and anatomy. We talked about VBI and anatomy and some of the other discussions. But I'd like to look at things a little more specific to this region. And a couple of things is one, the vertebral arteries, as they come up, as you know, eventually they're going to land in and merge and form the basilar artery. Before they do, though, they send off a couple branches that make their way down the front of the spinal cord, known as the anterior spinal artery. Doesn't make its way all the way down. That gets fed at different levels, but it's kind of the beginning at the top part of the spinal cord in the front. Meanwhile, it sends off a huge or important branch known as the PICA, posterior inferior cerebellar artery. It sneaks out. It's based after what it does. It just wraps around, goes on the bottom of the cerebellum and the backside of the cerebellum. But meanwhile, these long branches, all of these ones that are jumping back to that cerebellum, they're plugging into the brainstem as they wrap around. So they aren't making a straight shot. They're also taking care of whatever level of brainstem they're wrapping around to get to that cerebellum. But there's a condition known as PICA syndrome that, again, will be one of those clinical discussions we'll have at the end of the brainstem lecture. This was just highlighting and just a little bit more showing the visual of it wrapping around, so supplying the lateral medulla region of that midbrain, but eventually goes back and takes care of the bottom of the cerebellum and the inferior portion, or the posterior portion of it, that's all. Okay, looks like I've just got plenty of highlights there for you. Okay, moving up to the basilar artery though. So as this thing goes up, a few major supplies, three big branches out of the thing. At the very end of it is basically entering in the circle of Willis and splitting into right and left posterior cerebral arteries. What do we know about those guys? We already chatted before. Makes its way, sneaks back to that occipital lobe, areas 17, 18, 19, all that stuff in the occipital lobe is where that blood supply is going. Meanwhile, though, there's two other big branches. These circumflex that are sneaking back, and there's a superior and an inferior cerebellar arteries, which I think I got the entertaining labels on. Here's your PCA, and here's our superior cerebellar artery. But basically, this is wrapping around, plugging into the top of the cerebellum, and then you've got the inferior version down here. The only difference is you've got posterior inferior cerebellar, anterior inferior cerebellar. So two major pathways to get the bottom half of that cerebellum. There is a little arrow here. We had chatted about it somewhere along the lines, I think, in anatomy. Cranial nerve 5, tic de la root, trigeminal neuralgia, just unrelenting pain of the face. And a lot of times, I think we had mentioned, there's thought to be a vascular cause. And if you look at the orientation of as it wraps around and as this SCA is sneaking out by it, there's some discussion that that artery is laying on that nerve, just pulsing and irritating, the nerve. Surgery procedure, go in, lift it off, and relieve that pressure. Heard pros and cons. I've heard people sing the praises of the procedure, and then a lot of people that are like in the no camp. So I really haven't, explored or researched enough to give you a nice summary or an accurate summary. But that's superior cerebellar artery. And so inferior, again, just sneaks off the basilar artery on the bottom part of things, and obviously going back to do the cerebellum. Meanwhile, you've got these, and I guess this thing disappeared pretty darn quick, not sure why, but these pontine nuclei are these little tiny small vessels. This is what I was referring to as small vessels, and also show that whole pattern of small vessel stroke. And if you look at it, they're on the front of this brainstem. They're on the front of the pons. The only thing I've told you functionally so far is all that motor stuff runs down the front of the brainstem. So when you talk about a pure motor stroke, yeah, we talked about internal capsule and maybe the posterior limb where all these corticospinal tracts are going through. But a pure motor stroke can also come about from these small pontine, vessels blowing out and doing the same thing too as well. So that's where I'm now kind of adding to your lacunar, background, if you will, is just don't directly relate small vessel lacunar strokes to that internal capsule diencephalon area only. In fact, I think frequency, the pons may be involved more than the internal capsule if you look at the stats. So that's a little discussion, as I said, of all these small vessels that are sneaking around to plug into the remaining of the brainstem. Not sure why this slide landed here. I think it was cut and pasted, or maybe just another visual to help you out, but it's all stuff we'd already had chatted about along the way. Okay, so occlusion. Did we look at that clip? I've forgotten again. I'm definitely losing my marbles about locked-in syndrome. Have we talked about locked-in syndrome? It's probably worthwhile. You've been at it a long time here without any entertainment. But basilar artery occlusion, anything that's going to blow out the vertebral artery pathway, and more importantly, the single basilar artery, which is now by its lonesome, doesn't have a backup of a right or a left. Once you blow that out, that's pretty drastic, as we said, to brainstem function. Brainstem function, top region, all the core stuff, alert, orientation, reticular pathways that are going up to talk to the thalamus. You lose those, you're unconscious. You lose those, you're not alert, you're not oriented. Meanwhile, cardiovascular centers, pulmonary centers, DRG, VRG, all that stuff we did in pulmonary and, back when, all of those guys are located in the lower part of this. But when you blow this out and you affect those, obviously it's your core, function you're losing. So the outcome is not necessarily too good, or it's a pretty poor prognosis often. And so if it's severe enough, individuals can develop locked-in syndrome. And basically it's taking out a lot of the brainstem, with the exception of maybe upstairs to cranial nerve 3 for your eyes, ocular movement. And so with locked-in syndrome, these people will be paralyzed, unable to speak, unable to move, function in terms of that. The brutal irony is sometimes the spinal thalamic tract, the pain piece, they can feel pain, but they can't react to it expressively or output-wise. But the only thing they may or may not have is the ability to communicate upstairs. This is still functioning, and use their thinking via their eyes, which is the case you'll see in this video. But locked-in syndrome, it's easy just to, unfortunately the prognosis is not a good one, so I'll let the story speak for itself. So hopefully...
You'll recall a man in Belgium made headlines around the world last week, and it was reported that he had been fully conscious for 23 years, while doctors thought he was unconscious.
A Utah woman can relate to that. She had a similar condition and lived to tell about it. John Hollenhorst joins us with her amazing story. John.
Well, Laurie, tomorrow is the 8th anniversary of a medical crisis that plunged the Utah woman into what's known as locked-in syndrome. She appeared nearly brain dead but was fully conscious. Some thought she should be allowed to die until one nurse noticed a spark in her eyes. Nisa Smith knows what it feels like when a fully conscious mind is imprisoned in a body that doesn't work.
Yeah, trapped.
She speaks and walks with some difficulty, but she's miraculously improved from 8 years ago when she seemed lifeless in a hospital bed and couldn't speak at all.
I wanted to call out for someone to come to the room, and I couldn't do it.
She's capable of enjoying her 3 daughters now. 8 years ago, her youngest had just been born.
She was up nursing her 1-month-old baby when she suddenly collapsed.
It was an apparent stroke. The following night in the hospital, she suffered a far more serious one.
In the middle of the night, after she was found slumped over and unresponsive, from then on she had lost everything.
I couldn't talk. I couldn't move. I couldn't do anything. But I knew what I wanted to say and do. But I just couldn't do it.
After brain scans, doctors feared the worst.
They called us together as a family and said, how you see her today is how she will be until you let her go. We recommend that you call the family together, tell her goodbye, and let her go.
The next morning, Smith was still motionless with her eyes open.
But a nurse came in and said, I think she's there. Do you mind if I do an experiment?
The nurse started by asking Smith to close her eyes, which she did slowly.
So the nurse said, Nisa, if you can hear me, close your eyes twice. And she very slowly closed her eyes twice. And that was a huge, huge moment of recognition for us that she was there.
Within hours, they'd learned to communicate in words, with Smith blinking her eyes as others spoke letters of the alphabet. It gave her hope. She began emerging from her prison several months later.
Just getting back into my world, I guess, being a mom.
After months and then years of therapy and hard work, she slowly regained much of what she had lost.
And we've just sort of been walking uphill slowly ever since, back to who you see today. She's a wonderful mother.
Her goal one day is to run with her children, a dream unthinkable until a nurse acted on a hunch.
Just to watch them grow and mature makes me happy.
Lisa Smith's sister, Jerry Marshall, recently published a book about her experiences. I'll Walk With You is available at Amazon.com or through her website. We have a link on KSL.com.
So again, pretty impressive when you look at that clinically. And again, think about it. As I said, all of your hemispheres, all that's fine. So she's sitting there, she can reason, she can hear, she can take the sensory input, but everything her frontal lobe wants to do, she can't execute. And, you know, hence the name obviously locked in, or, you know, as she adequately described, as being trapped. I can't fathom the frustration. You know, I'd probably blow another blood vessel being so frustrated. You know. So that's locked-in syndrome, though. I won't. There's a whole nother video just discussing it. Casually heard them make the comment is, you know, there's a sense of, oh, this woman's unconscious, and you know, kind of getting pushed off into just a plateau of care, and, you know, euthanasia and right to die and all those issues. And so this is a discussion, just an individual with locked-in syndrome. You know, it's a pretty long 15-minute clip, though, so if, you know, you're interested, take a look at it. It's certainly, you know, we don't have the time or space here, I guess, to open up that discussion, but pretty thought-provoking, I guess. So that spacer artery, as I said, really highlights the functional role of that brainstem being at the core of everything. And again, the upper part of the brainstem's hanging on. So again, her alertness, she is alert, but not able to act functionally at all, other than, you know, maybe with cranial nerve 3 at best up there. So I think what I'm going to do is park the bus. We've all paid our dues today. So why don't we do that? We'll pick this up. Just in case, I'm sure you're not, but just in case you're wondering, you look at the schedule, and it says, you know, I think we're like a half a lecture or a lecture behind. That last week, it says, you know, independent study. I put it down that way just as a standard. I know it's always going to be an overflow, so we'll probably, you know, that's where we'll be finishing and making everything fit. But with a little luck, I'll get done before that last Friday is my goal. I'd have to do this, but all right, now the pressure's on. All right, you guys have a good day. I will, Manchester, I'll see you on Friday. Worcester, you guys have a good week. Good luck Friday, and see you next week.